In order to improve the lot of cancer survivors, first of all, we need to be able to count them. And this hadn't happened in the UK until 2007, 2008, when we identified the prevalence of those living with cancer and indicated that many more people were living with cancer than people had expected, but they were not all living well. Then we needed to understand how the cancer story has changed. We did some secondary analysis of the data and divided people up into 3 different groups to enable us to think about different needs for different people. Then we needed to work with a whole range of stakeholders to decide what were the best interventions to help people. And this led to the development of the recovery package and risk-stratified follow-up pathways. And over the last 10 years, across the UK, we've been testing risk recovery package and risk-stratified pathways as a way to improve the lot of cancer patients. But what we've learned is not only does it need a model and resources, but it is a big culture shift. And that is probably the biggest barrier to implementing survivorship care. Clinicians who see patients need to look at things in a different way to recognise the complexity of cancer treatment. There's one group of patients where really the main priority should be recovery, but many of the resources go into interventions which do not add value, such as some follow-up appointments. So there's a real culture shift in terms of getting clinicians to prepare people to manage their care with support, but not requiring hospital appointments. And this is a big challenge to clinicians who have been used to seeing their patients over many years. Then there's another culture shift of recognizing that there are patients now who have incurable disease, but may live with that incurable disease for many years. And this requires a very different sort of support. And finally, there's a culture shift in recognizing that some of the patients who used to die very quickly are now having new anti-cancer treatments and living for months and now years. And that needs a different approach as well. We've had some initiatives that have succeeded and some initiatives that have failed. What has worked best is when we have a top-down and bottom-up approach. For example, in Northern Ireland now, we have a situation where patients with breast cancer all have the recovery package, and 60 to 70% of them will be entered into self-managed follow-up. That required both a demonstration to clinicians that this was a safe and appropriate thing to do, work over a considerable period of time, appropriate project management and ministerial support. So to make that culture change, it doesn't happen quickly. It needs a sustained approach over several years with a bottom-up and top-down approach. What we've now understood is there are 2 important areas to look at in the future. The first is to ensure that a quality of life metric and patient-reported outcome measures are integrated into data collection so that we can demonstrate the benefit of our interventions. The second is really focusing on the treatable but not curable group, which are going to be the growing group for the future. So over the last 10 years, there has definitely been very important shifts in understanding the change in cancer. But I think for any young clinician coming in, I would say you have to play a long game.